What's up, everybody? Last month, Dan Roper asked me to talk a little bit about D-dimer and when to use it, how to use it. I was not able to be at that meeting because I was working, so I figured I'd put that in a little video. Before that, though, I think we should start with a reflection, like all of our monthly meetings. Um, just as a disclaimer, this reflection does have a bad word in it, so just keep that in mind. Don't play it super loud in the middle of a pod or with your kids running around or something like that. But the message is so strong that I felt that even because this one bad word, I think we should probably all hear this and get us in the right mindset.
Sit or lie comfortably, quietly. Allow yourself to be here, fully, in this moment. With your eyes closed, begin to connect with your inner world of thought and feeling. Gradually, let the horseshit of the external world fade from your awareness. If you find your mind wandering to other thoughts, don't let it concern you. Just acknowledge that all that shit is fucking bullshit. You're here now, in this place, with your inner stillness. Those bitches can't get under your skin. They can't even. Take in a deep breath. Now breathe out. Just feel the fucking nonsense float away. Take full, deep breaths. Breathe in strength. Breathe out bullshit. Allow your breathing to discover its own natural, unhurried pace. If your thoughts drift to the three-ring shit show of your life, bring your attention back to your breathing. And with each breath, feel your body saying, "Fuck that." With passive acceptance, just allow distracting thoughts to float by. Fuck that. With each breath you take, your thoughts become lighter, and all the soul-eating cocksuckers just fall away into nothing. Take a moment to appreciate the silence. Those assholes can't piss all over a purity like this. You are weightless, timeless, without beginning or end. Completely relaxed and free of thought. And as you slowly open your eyes, greet the world and everything in it with a new, beautiful breath of fuck that.
All right. Breathe in strength, breathe out bullshit. I'm feeling good. So let's get started. So we're going to try to do a little Star Wars theme because of all the Star Wars hype recently. And maybe this will help us to remember some of the stuff we're going to talk about. That's enough of that. So basically, we'll talk about D-dimer today and a little bit about Wells criteria. So let's move on. So basically, when you order a D-dimer, it's good to first think a little bit about how you're going to order it and who to order it on, as opposed to the D-dimer being just a screening test, kind of like a troponin that we do in most of our chest pain patients. The first thing you're going to want to do is assess your pretest probability before ordering a D-dimer. So what does that exactly mean? Well, in any patient that PE is in the differential, you want to put your patient into a kind of risk stratify them into one of three groups: um, low risk, moderate, and high risk. And you can see the percentages of the probability of a PE there next to them. Low risk would be less than 15% chance of PE, moderate 15 to 40, and high risk greater than 40. So that's kind of step one, is putting your patient into one of these three groups. How do we go about doing that? Well, there's two main methods. One is to use the force, and just by looking at the patient, determine you probably don't have a PE or you probably do. Um, and then the other option is to use a scoring system. The one we're most familiar with is probably the Wells criteria. Both of these options are acceptable to risk stratify your patient pre-test wise. There are some studies suggesting that if you do the criteria method, it's a little bit better, but both of them are options. So let's use some practice patients to see how this works. So our patient number one is a young, healthy female, no previous past medical history, coming in with stabbing chest pain. Basically, if we want to look at this patient and develop our concern for possibility of PE, if we want to use our gestalt, right here the patient is extremely flat affect, very boring, nothing exciting at all about this patient. Um, she does describe stabbing chest pain, but overall you think there's just a low probability that she has a PE, and we'll put her in the low risk category. And that's one method. The other method would be to use the Wells criteria. And here's the Wells criteria. If you Google Wells criteria and a calculator, the MD Calc will come up and you can go right through and this will help you calculate it for you. And here's the main criteria listed. For this patient here, basically she has none of these. So her overall Wells criteria score for PE is 0, puts her in their low risk group. Anything less than 2, you're going to be in the low risk group. A second patient here is this gentleman here. He said he got real short of breath somewhat suddenly, and he describes he's coughing up some blood. And on a side note, he does say he's very super sweaty pretty much all the time. It's tough to know what to make of that. His friends do confirm that pretty much every time they see him, they find out that he's just extremely sweaty. So that doesn't sound like a new thing. That sounds like more of a chronic thing. But overall, he's describing some shortness of breath, coughing up some blood, maybe a little more concerning than our last patient. So we'd probably, with our gestalt, put him in the moderate risk category. If we did the Wells criteria for this patient, we'd find that he's 2 or greater with a heart rate. He's a little tachy, gets a 1.5 for that. And he does have some hemoptysis, gets a point for that. Puts him over 2 and into the moderate risk group. And finally, here's our last patient. He looks absolutely horrible. Describes sudden onset shortness of breath. Um, he can't even breathe, even with this oxygen contraption that he has hooked up. Looks pale. I feel like I can even see some cancerous lesions on his head and his cheek area. Um, I'm thinking right off the bat, this guy's got a PE for sure. It's probably a submassive or massive PE. So we'll put him in the high risk category. And the Wells score for him, 3 plus, because we feel like PE is likely diagnosis. He's tachycardic. He's definitely been, as far as the immobilization or surgery in the previous 4 weeks, his whole body is like one big surgery. He's had several recent procedures. So he's getting a 1.5 for that. And then on the bottom there, he does have a malignancy. So he's at 7. Anything greater than or equal to 5 puts you in the high risk group. The good thing about doing the Wells score through MD Calc or any type of calculator is it actually tells you what group the patient is in after you check off the boxes. So you don't have to remember, is it greater than 2 or less than 2, 0.5, or exactly, you don't have to remember all that. It'll calculate it for you. So once you have your patients in the low, moderate, and high risk groups, and you've assessed the pretest probability, now we can move on to what you do with that information. Starting with the low risk patient, the first thing you're going to do is you're going to perform the PERC rule on the patient. So I did not put this in here, but similarly to what we did with the Wells score, you look up on Google Calculator, MD Calc, and there's a check boxes for the PERC score. And if the patient is PERC negative, you're done. No PE, you don't need any further testing. If the patient in the low risk category is PERC positive, then you proceed with the D-dimer testing next. Moving on to the patient in the middle, the moderate risk group, you start with the D-dimer in this patient population. If the D-dimer is negative, then you're done, no PE. D-dimer is positive, then you continue with the CT or VQ scan depending on your renal status. And finally, the high risk group on the right, you're not going to start with D-dimer at all. You're going to go right to imaging in this patient population because the risk of PE is so high, greater than 40%. Um, so pretty much the hard part in the beginning is getting the patient into the right, kind of stratifying them into the right risk group. And then after that, this particular algorithm, pretty straightforward. I think where we get into a little trouble is if in the low risk group, if we immediately go to D-dimer, we may be missing a section of patients that we could have done the PERC rule and sent them home without risking a false positive D-dimer and extra imaging, that type of thing. We also get into trouble in the high risk group if we did a D-dimer, happen to get a negative one, which would be a false negative. That could get us into some trouble as well. I did want to mention one more thing. There is a group, essentially a no risk group, where PE is really not in your differential, and you're not going to go down any type of algorithm with these patients. So if you look in the upper left, gentleman has a lightsaber through his chest. He's certainly going to have chest pain and maybe some shortness of breath, but we're clearly not going to risk stratify him and do a PERC rule and all that kind of stuff in that guy. Same thing with the upper right. This gentleman has a little bit of a shortness of breath, but you can see he's got a runny nose. He's got a bit of a fever. This is an infectious issue. This is not PE, so we're not going to go down that path. And finally, the patient on the bottom. We all know this patient comes in almost every day, freaking out, hyperventilating, super annoying. Already had 5 CTs in the past year, all negative for PE. Multiple D-dimers have all been negative. Even if this patient's a little tacky because they're freaking out, you don't need to go down the pathway here. You just, document I'm not concerned about PE and get the patient out of the ER. So that's it. Thanks. Hopefully this helps a little bit and a little bit of a review.